Dear Translational Medicine leadership, dear colleagues, I am very pleased to announce you my 3 months progress, which I have made since I have become the Translational Medicine PhD student. My topic is a kind of a borderline topic between neurology and cardiology, because I am investigating the role of left atrial strain in neurocardiology. Briefly about myself, my name is Henriette Mészáros, and I work at the Heart and Vascular Centre of Semmelweis University as a cardiology fellow and a PhD student. Here you can see my supervisors, and my scientific methodology supervisor is Rita Nagy. In my everyday practice at my workplace, I can see that the detection of atrial fibrillation requires often unnecessary number of prolonged monitoring. So that is why my mission is, with the help of my PhD research, to decrease the necessity of prolonged monitoring. So a quick overview about my 2 projects which are in progress. One is a systematic review and meta-analysis, and the other one is a protocol of a single center randomized trial. First, I would like to speak about my first project. We are investigating the association of left atrial strain and the occurrence of atrial fibrillation. I would like to highlight some key information about the background. Old age comes with comorbidities, of course, we all know it. One of them is a left atrial remodeling, which can result in atrial fibrillation. From the mechanism of atrial fibrillation, we all know that it is a prothrombotic state and can cause cardioembolic stroke. Until today, the gold standard diagnostic method of atrial fibrillation is only prolonged ECG monitoring, but all cardiologists agree that it is kind of expensive and there is no consensus on the appropriate modality and duration. So that is why derives the question of using non-invasive yet sensitive method for the prediction of the occurrence of atrial fibrillation. This could be a very promising method, the so-called left atrial strain analysis, which could assess the left atrial remodeling. Our aim with this study is to limit the range of patients who need prolonged ECG monitoring. Here you can see our clinical question: is the decreased LA strain associated with the occurrence of atrial fibrillation? I would like to introduce you my PICO framework. We would like to deal with cardiology patients who had this left atrial strain analysis, and we would like to compare 2 groups of them, the ones who were detected with AF during follow-up and the other ones who weren't, and regarding their left atrial strain parameters. And our hypothesis is that patients with atrial fibrillation have decreased atrial strain. I would like to also highlight the clinical implication of our study. We would like to determine a cutoff value of LA strain, which predicts atrial fibrillation and also the recurrence of stroke. I have made my systematic search in 5 databases on the 8th of November. Here you can see also my search key. Here is my flowchart. I am now at the end of the full text selection. Now I think I have 40 full texts, and in the upcoming days I am starting the data extraction part. Now we are coming to my second project, in which we are aiming to investigate the effect of high versus low mesh density device on left atrial strain in patients with patent foramen ovale. Why is it so important for us? Of course, because about half of all cryptogenic strokes are related to patent foramen ovale. When we diagnose PFO, it is an approved secondary prevention to perform PFO closure. And according to the newest literature data, PFO closure is superior to antiplatelet therapy only. But of course, as we can imagine, we are implanting on the atrial septum a metallic device, so it can lead to both electrophysiological and mechanical changes in the atria, which can result in atrial fibrillation. Briefly, we are using 2 main types of closure devices. The one is with the high mesh density. These are the older devices, and there is new at the market, the PFO closure devices with lower mesh density. Our aim is to compare the 2 different mesh density types of closure devices regarding these changes which can occur in the atria. Here you can see our clinical question. We would like to deal with adult patients who were referred to PFO closure. We would like to compare the 2 mesh density types regarding change in left atrial strain as a primary outcome and in atrial fibrillation as a secondary outcome. Our hypothesis is that PFO closure with low mesh density device is non-inferior to PFO closure with high mesh density device. Also, we have, of course, here huge clinical implication. With the appropriate device selection, we could decrease the rate of postoperative atrial fibrillation. We have made the protocol drafting, and our main inclusion criteria is that cryptogenic stroke must be confirmed on brain imaging, most likely on MRI, and PFO has to be also proven, assessed by transesophageal echocardiography. And of course, we are heading along the newest guideline recommendations. And our main exclusion criteria is the atrial fibrillation at admission. We are planning a two-arm, non-blinded single-center trial with two main interventional arms. One is the PFO closure with low mesh density device and the other with high mesh density device. And we are planning also a registry arm, a control group with patients who were referred to us but are not eligible for PFO closure for different several reasons. As an outcomes, as I mentioned, we are aiming to investigate primary the change in left atrial strain. And as a secondary outcomes, the most important ones are atrial fibrillation and recurrent stroke. So where are we heading now? I would like to submit my first project at the beginning of May next year, my second project at the middle of summer, and we are also in a planning phase of a third project, which will be a robotic TCD monitoring to detect cerebrovascular events during structural cardiovascular interventions. We are planning to have a prospective registry, and our planned start date is the beginning of next year. I would like to thank you for your attention with one of my favorite quotes. I think it is very appropriate for this whole program. Today is your opportunity to build the tomorrow you want. Thank you.
Thank you and congratulations on your presentation. In the protocol you mentioned that in the eligibility criteria that you would like to examine the patients with transesophageal electroechography. I just wanted to ask that why isn't the transthoracic echography is enough?
Oh, thank you. Very nice question. Because it is the gold standard method of diagnosing PFO, so the transesophageal echocardiography. Because with the transthoracic echocardiography, we couldn't visualize the left atrium and the septum between the two atria well enough. So that is why transesophageal echocardiography is performed, because we have to see exactly the septum, and we have to make a specific test of the provocation of this shunt. So that is why we are using this specific method.
Thank you.
Sorry, we must at least two questions ask. Can we go back your recruitment criteria? I mean, in your, so you have two arms. The one arm is that when you actually do your intervention, and the second one, then you said something that you include those in whom, for some reasons, that disclosure cannot be done. Yes. Is this correct? So doesn't it introduce a bias of this study? Because, I mean, so what kind of reasons? What are the reasons why you have to exclude patients from that group?
Thank you for the valuable question. Maybe that we can see during transesophageal echocardiography, we can see a very simplex PFO anatomy, which couldn't be catheterized during the intervention, or during the thorough diagnostic evaluation of the stroke etiology. Maybe there can be other stroke risk factors which are more likely to be contributed in the stroke. So that is why we treat them, because it is very important that we only treat PFO as an etiology of stroke when no other etiology factors are can be proven. So if there is another which is higher risk. For example, the most important is atrial fibrillation or carotid plaques or something that then we don't. And sometimes our patients are referred to the neurocardiology lab before the end of this thorough diagnostic evaluation. So that is why we are meeting patients who are not eligible for us.
You and your supervisors are the really experts on this, so fine. But on the other side, if we introduce, I mean, a different kind of control group, then the beneficial outcome may come from two different reasons. One is the treatment, and another one is that actually this second group actually have higher risk for some reasons. Mm-hmm. So you must be very careful or reconsider this.
Yes, we have to be very careful in patient selection. Which patient benefit the most of it and which don't. So that is why it is a very hard question.